يعطيكم العافية. تسمعوني ولا بدكوش تسمعوا؟ أنا جاي أشكركم اليوم، يعني بصراحة يوم الخميس فقتوا توقعات. يعطيكم ألف عافية. إشي بسعدنا بصراحة إنه التعب اللي تعبناه معكم، وأكيد التعب واضح منا ومنكم، جاب نتيجة. وبصراحة يعني العلامات رائعة. الأساتذة اللي امتحنتوا عندهم يعني كانوا متفاجئين كونكم أنتم يعني أول مرة بتمتحنوا أوسكي وأول مرة سريري. فبصراحة عن جد عن جد يعطيكم ألف عافية. بدنا نكمل، ضايلنا 3 أسابيع دراسة، بدنا نكمل على هذا النهج وما بدنا نتعب، لأني لاحظت بالثيوري الامتحانات شوي بلشتوا، شوي بعض منكم بلش يتراجع. فبدنا نجدد النشاط. بعرف الظروف اللي حوالينا شوي بتخلي الواحد يلتهي، لكن بنعرف إنه كل حدا بالحياة له واجبات لازم يعملها أول شيء. بدي أأكد على موضوع الغياب كمان. في ناس بلشت تتجاوز الغياب، توصل لحد معين، وإحنا حكينا ما رح نتهاون بموضوع الغياب. حتى لو كان الغياب بعذر لا يمحى الغياب، بظل موجود، يسجل إنه بعذر إذا قبل العذر. بدي أكد على موضوع الامتحانات الثيوري، ما تغيبوا عنها. في ناس نحط لهم 0 ما انقبل عذرهم. وإذا رح ينعمل ميك اب، الميك اب يكون استي ورح يكون صعب جدا، فننتبه لغيابات امتحانات الثيوري. وبس، يعطيكم ألف عافية، وإن شاء الله يا رب بالامتحان الأوسكي الفاينل طبعا رح يكون أكثر جدية. نمشي على نفس الانضباط وعلى نفس الاجتهاد. يعطيكم العافية.
عم بتشكر الدكتورة جمانة لأنها بعرف قديش تعبت معكم خلال الكورس، من حتى قبل ما تبلشوا بجزء من أشهر ويتحضر للكورس، فجهودك مباركة دكتورة جمانة. اوكي، رح نبدا اليوم بالفيرست لكتشر بالنيورو ساينس روتيشن let's say. As you know, neurology one of the topics that you will take through the 5th year next year inshallah. We would like to give a simple presentation today about the most common neurological symptoms, so that it will help you next year in taking history while you are doing your rotations. So can anyone of you tell me what do you expect, or what symptoms a neurological patient can present with to the ER or the clinic? تفضل. Sorry? Yes, headache. Anyone else? Yes, tremor, loss of consciousness, weakness, memory problems, yes. Numbness, sensory symptoms. What else? Yes, dizziness can be some. Most of the time, dizziness is internal medicine issue, but we are called also as a neurologist to evaluate whether this dizziness is from a neurological cause. Usually, it is vertigo that is due to a neurological issue. Anyone else? Yes, paralysis أو هي نفس weakness. Okay. So these are most of the symptoms that you can or you will face during a neuroclinic or emergency room. So headache, weakness, numbness, altered mental status or loss of consciousness, imbalance, which you forgot, I think. Abnormal movements كمان. Beside the tremor في عندنا احنا chorea, dystonia, and others. Parkinson disease, one of them as well, and memory problems. Okay, as any other history, I think you pass it through the general format of the history taking. So it's important to know the onset and the duration and the pattern of symptoms. Especially, for example, when you are dealing with a case of a stroke. The onset is very important for us. Why? Because it affects our next plan. So if a patient presented with the first few hours, let's say up to 4.5 hours, the management will be different, and we will speak about that in the weakness part. Also, it's important to know whether the symptom is persistent or intermittent. For example, if a patient is coming with a persistent headache, the first onset, this is not a simple headache to deal with, while a patient who is coming with frequent attacks, which are intermittent from time to time, we don't consider this a red flag to worry because it's not the first time, but of course this patient should be evaluated. Also, if the symptoms are improving or getting worse. Also, this is important, especially in cases of a stroke and in young patients who are presenting with weakness. Why? Can anyone give us an example of a disease that causes weakness in young people? Yes, في حدا جاوب هون. Multiple sclerosis. So usually attacks of multiple sclerosis are transient and improve with time. So within 2-3 days, even without the treatment, patients can go back to the baseline. Also, it's important to know what triggers the symptom or what are the exacerbating or aggravating factors. For example, a case of migraine, usually patients will report photophobia, phonophobia. Also, it's important to know the associated symptoms, like cases of migraine, they may also present with nausea, vomiting. So till now, as you can see, the format of the neurology history is almost similar to other systems, but we have some specific points to focus on. Okay. And the other parts, you should also cover the past history. You should know whether the patient is having, for example, hypertension, diabetes. A case of a stroke, for example, you should know the risk factors like hypertension, DM, hypercholesterolemia. This should be kept in mind. Family history also is very important. We have many neurological illnesses that are of genetic cause. One of them, for example, is epilepsy. So it's important to take a good family history, and sometimes this will affect your decision in giving treatment or not. So usually in the first attack of seizure, we don't treat patients directly unless we are having some certain points like an abnormal exam, an abnormal MRI, abnormal EEG. Sometimes only a positive family history will let us consider starting treatment even from the first attack. Also, social drug history is also important. One of your colleagues mentioned the tremor. So tremor sometimes can be drug-induced. Many times we are called to evaluate patients in the ICU due to tremor, and the issue will be just only they are taking a beta agonist. So sometimes drugs are the main issue. Also, the social and occupational history are very important. For example, if we are dealing with a case of a stroke, which was a minor one, many times you can face a patient who is having a stroke, but the symptoms are minor, like mild dysarthria, for example. So you should ask yourself whether shall I take the risk of giving a thrombolytic therapy or not, because thrombolytic therapy has a risk of bleeding. So when you go back to the social and occupational history, and you know the patient, for example, is a teacher, so despite dysarthria is a mild symptom sometimes, but it can affect his quality of life. So in this case, you should give thrombolytics. So it's very important to know all these components when you are dealing with a case in the emergency or the clinic. So we will start speaking about tremor. Tremor is one of the most symptom or movement disorder symptoms that a patient can present with, and usually they present to the clinic, so it's not an emergency. It's important to know, of course, the time course, the onset, and how the tremor is progressing. The age is very important because it can let us categorize the tremor, whether is it essential tremor or something else. As we said, we should cover the medication history and ask about things that may improve the tremor or make it worse. One of the exacerbating factors for tremor is, anyone can answer? Yes, so most of the time we have what's called physiological tremor, or even the essential tremor can get worse in an anxiety. Like in exams, many people, they won't be able to write well due to that. And some things that can improve the tremor, mainly most of the time we ask this question abroad in other countries, like alcohol intake. For example, essential tremor patients, they usually improve with alcohol. Also, it's important to know the family history. Usually, essential tremor, for example, has a positive family history. So types of tremor, this is mainly in the examination. So it is categorized to three separate groups, which are the rested tremor, action or postural, or intention tremor. Rested tremor means when you examine the patient while his hands are over his knees, like the first picture on the left. Postural tremor is when you ask the patient to extend his arms in front of him. And the intention tremor is when you ask the patient to do the finger nose test, the one for cerebellar signs. So when they reach the target, the tremor will start. This is called intention tremor or kinetic tremor. So as said earlier, the essential tremor is often familial, so you will find a positive family history. And it is believed that essential tremor is part of physiological tremor as well. And it increases with age, and it has a bimodal distribution, so between the second and sixth decades. So in general, الأعمار اللي راح تشوفوا فيها the patients who are having essential tremor are between 20 to 60 years. This is the main time when the onset starts. And it is slowly progressive. So it's important to know the progression of the tremor, because a slowly progressive tremor, this is something almost a benign thing. And we don't treat essential tremor always, because if it is not affecting the quality of life, you just leave it. And based on the examination, essential tremor patients usually have a postural and an action tremor. This is a very important point. And they tend to affect the hand, head, and voice. So many times they will have vocal cord tremor even that can affect their speech. And it gets worse with anxiety. Another disease that can cause a tremor, and we see it commonly, is Parkinson's disease. So we should differentiate between the two types, because if a patient who is in his late, like 50s, 60s years old, and presenting with a tremor, it's important to know whether this is essential or Parkinson's disease, because the treatment will be completely different. So in summary, as we said, the essential tremor has a bimodal distribution regarding the age, and you will find the family history always, most of the time there. While Parkinson's disease, most of the time there is no family history, despite that some genetic mutations were found to cause Parkinson. And the usual age for Parkinson's disease is above 60. However, still this is not let's say, a must, because some patients can present early on. We met patients having Parkinson in their 30s, but commonly they present with old age. Response to alcohol, as we said, essential tremor has this point, while Parkinson's disease will not respond to alcohol intake. Essential tremor is a postural and a kinetic one, while Parkinson's disease, it is a rested tremor, which means you can see it when the patient puts his hands on his knees. So when they extend their arms, tremor most of the time disappears. The frequency, as you can see, essential tremor has a higher frequency compared to Parkinson's disease. The handwriting is most of the time affected in essential tremor, while in Parkinson's disease they have what is called micrographia, which is small handwriting. Also, the tremor, if it is severe enough, it can also affect their handwriting, but most of the time we see micrographia. Regarding the facial expressions, they are preserved in patients with essential tremor, but Parkinson's disease patients have what is called mask face. You cannot tell whether this patient is happy or sad. And finally, regarding the voice, as we said, essential tremor can affect the voice, and you can find vocal cord tremor, while in Parkinson's disease, they tend to have dysarthria or hypophonia compared to essential tremor. And Parkinson, as you know, they have shuffling gait and freezing, while essential tremor, it won't affect the gait. So these are the most important points. Just quickly about Parkinson's disease, patients usually have rigidity, which is increase in the tone, and they have also slowness, which is called the bradykinesia. This is the term that we use to describe slowness, bradykinesia. Also, they have a stooped posture, so they tend to have a flexed position of their trunk, and they used to shake. Of course, tremor is not a must in any patient with Parkinson, so the most or the core feature in the criteria is حدا بيعرف؟ No. Bradykinesia. So bradykinesia is a must plus any of the other symptoms. It's important also when you meet a case of a neurological illness, especially when you are dealing with a neurodegenerative disease. Neurodegenerative, one of them is Parkinson's disease, dementias, Alzheimer, etc. To ask about the non-motor symptoms like cognitive impairment. Most of patients with Parkinson, they present with sort of dementia and some mood problems, and they tend to have also psychological issues like impulsive disorders. حدا بيعرف ليش؟ Possibly, yes, but في another main cause اللي هو the drugs. The drugs that we use to treat Parkinson's disease can cause impulsivity. Also, autonomic features. Most of the time, patients with Parkinson, they report postural hypotension or dizziness. So you should check for postural hypotension when you are dealing with this complaint. Also, sleep disturbance. They tend to have restless leg syndrome. They have REM sleep behavior disorder, reported as nightmares, kicking movements. So usually the partner will complain about the quality of sleep. And we talked about already the psychological symptoms. Okay, starting with weakness. Weakness is one of the most common presentations that we deal with in the emergency room. So it's important to describe when this happens. So we usually ask when the patient last seen well. This is the question that we use, because it's very important to decide whether he is still in the window, which is 4.5 hours, or not, in case you are dealing with a case of a stroke. Because as I said in the beginning, it differs when treating this patient. So if he's still in the window, you can give with IV thrombolytic therapy, and this is a very top emergency in our field. While a patient who's out of window, you will deal with it as a cold case, despite it still is an emergency, and stroke can be presenting with severe neurological deficits. It's important to know whether this weakness also was sudden. For example, a stroke is a sudden weakness, while a patient with Guillain-Barré syndrome, they present with a gradual onset, and it tends to increase with time. Also, when you are dealing with a case of a stroke, for example, it's important to know the progression. Patients with Guillain-Barré, they tend to worse with time, and it is ascending paralysis, most of the time triggered by an infection. While patients with a stroke, most of the time they tend to get worse with time. However, if they are improving, you are possibly dealing with TIA, which is a transient ischemic attack. So if the patient told you that I am improving, there's no need to give thrombolytic therapy. This is why it's very important to take a good history. And also the localization. Our job in neurology is to localize where's the problem. And you need to be very expert in anatomy, because if you don't know that, you will not be able to decide where could be the problem, and you cannot guide the radiologist that we work with them hand to hand, because our main investigation workup is doing brain images. So it's important to guide the radiologist by the art of localization. So when you are dealing with a left side weakness, you know that we are possibly having a stroke, for example, in the right hemisphere. And you need to be more accurate. For example, if there is cranial nerve deficit, you need to know which part of the brain is this nerve originating from to guide the radiologist in a good way. Okay, another point is associated symptoms. Patients with stroke, I'm focusing on stroke because this is the case that you will proceed with during today's evenings or before the afternoon sessions. So it's important to know whether there is sensory symptoms, because patients with a stroke tend to have also numbness, tingling. What else? What other symptoms a patient with a stroke can present with? Possibly, yes. What else? Tremor? Numbness, yes. No sensory symptoms. Is she more common? Amnesia? Not that much, to be honest. Yes, so speech disturbances like dysarthria or aphasia, and we will talk about these. Okay, a history of a previous stroke is very important because any patient develops a cerebrovascular accident like a stroke or even an MI, he is prone to have another stroke in the future. So it's important to take this point while taking history. And if the patient is having risk factors like hypertension, diabetes, or high lipid profile, and it's important to know whether he's taking medications or not, because if a patient presented with within the window of the 4.5 hours, and you are planning to give thrombolytic therapy, and you found your patient is taking already warfarin or other anticoagulant, this is one of the contraindications to proceed with IV thrombolytic. So that's why drug history is extremely important. Family history of strokes, yes, it can give you that this is a possible risk factor, but may not help that much in stroke. And of course, you should cover whether the patient had previous surgeries. Why? Because if a patient had a recent surgery, like 1-2 weeks ago, a major one, this is one of the contraindications for thrombolytic therapy, not only in stroke, but also in MI. And you will pass through this in the internal medicine rotation. Okay. It's good to know if the patient also seek medical advice or was evaluated by someone else, because you don't need to repeat. If he had already did a CT brain or an MRI, of course you should ask about that, because this will save your time. And it's important to ask whether the patient symptoms are improving or getting worse. As we said, in cases of weakness, if we are dealing with a case of MS, usually patients tend to improve with time. Stroke patients, they usually tend to get worse unless the stroke is minor or it is a transient ischemic attack. Patients with Guillain-Barré syndrome, for example, they tend to get worse with time, and they may reach a point where they are put on a mechanical ventilator if they were not treated properly. And as you can see, the last point, which is whether this weakness is affecting quality of life, because it depends whether you need to treat this symptom or not. Not every weakness needs to be treated. If it is a minor one, improving with time, so you don't need to treat. Or like I said, in cases of, for example, sensory symptoms like numbness, many patients with MS, they present with acute sensory deficits, like tingling sensation and numbness. Usually we leave it untreated, because usually we treat MS with, anybody knows? With methylprednisolone, so for 3 to 5 days most of the time. So if it is just a minor attack, you don't need to give the medication. Okay, speech. So when you evaluate a patient with a stroke and he's presenting with speech problem, we need to cover some points in the examination. Like you need to ask the patient to write, to read, to repeat, and you should assess comprehension. حد بيعرف كيف؟ Sorry? Yes, we ask the patient a question. For example, where do you live? Or what's your name? So if he has intact comprehension, he should answer you properly. Also, we can give commands to the patient, like raise your right upper limb, or raise 2 fingers in your left upper limb, or touch your right ear. You can give simple or multitask commands to test comprehension, and also fluency. Fluency, you can, while doing a conversation with the patient, you can assess the fluency, whether this patient is fluent while you are talking to him or hardly speaking and producing words. It's very, very important to differentiate between types of aphasias. So we have the most common two types, Broca's aphasia and we have Wernicke's aphasia. حدا بيعرف يميز بيناتهم؟ تفضل. Yes. طيب Yes. Good. So as your colleague said, the Broca's aphasia, usually called motor also aphasia, because the patient has problem producing words. Either they are, sometimes they are completely mute. They don't produce any word, but still they can understand you when you give them a command. The patients can read, they can write. So when they want to tell you something, usually they write. So Broca's patients, they understand what you are speaking, but they are most of the time mute. They cannot produce words. That's why it is called motor aphasia. While Wernicke's aphasia, which is the other name, sensory aphasia, patients have problems with comprehension. So the patient is fluent, he is speaking fluently, but the component of his speech is not comprehensive. So that's why we call it word salad. So تسأل أنت المريض سؤال معين هو بيجاوبك بمجال ثاني تماما أو حكيه بيكون مش مفهوم. Also, these patients are, beside being fluent and have incomprehensive speech, they will not able to repeat or read or write. So, اللي نعرفه إنه مريض البروكاس aphasia, when you speak with him, he understands you and comprehension is intact. While patients with Wernicke's aphasia, the comprehension is impaired and the patient will not understand you and they have a preserved fluency. Okay, one of the common symptoms that we deal with is headache. Headache, it's important to know how to deal with headache because it's either a very simple thing or sometimes it can present with very serious complaints. So it's important to know whether this headache is for the first time or it is recurrent. If it is recurrent, this is possibly a cold case, while if it is first onset severe headache, that's why assessing the severity is important. You should be considering this as a red flag because you are dealing possibly with a subarachnoid hemorrhage, aneurysm, possibly sometimes strokes can present with headaches. While if the headache is chronic over the last months, intermittent, coming just for a few hours and comes and goes, this means we are dealing with other possible simple causes like what? Migraine, tension type headache, and the cluster headache, despite being one of the types of primary headaches, and it's not an emergency, but it is very, very painful. So most of the time, patients they arrive to the ER. Then the pain where is the pain located? Most of the time, the cluster. Anybody knows? Yes, it's usually periorbital, and it is described like stabbing pain. So it's important to know the location. Migraine patients, usually they have what? How's the presentation of the headache? كلهم بيكونوا recurrent, بس بيكون one part of the head, either right or left. Sometimes it can be bilaterally in rare occasions. With tension type headache, the patients will describe as a band-like because it is all over their head and it is tension-like, pressure-like in nature, while migraine is a throbbing in nature. So it's important to know how do these headaches present. Also, your colleague mentioned nausea, vomiting. Most of the time, those primary headaches present with nausea, vomiting. حدا بيعرف إشي ثاني غير هيك? One of the triggers and also what is called aura. اللي هو yes, they have photophobia, which is sensitivity to light, phonophobia, sensitivity to sounds, and sometimes osmophobia. Some odors may also trigger the headache, and sometimes these are called, let's say, auras. So most of patients with migraine, they have an aura. They know that the headache will start very soon. And triggers also beside the whole light, some odors, also stress, especially intention type headache. Usually those patients describe stressful conditions in their life or their work is a little bit stressed. It's important also to know whether there is fever with this headache. Why? Yes. So we should think of infection, mostly meningitis in our field. Okay, this slide mentioning you should ask about the traumas, of course. A patient with a trauma, of course, will be brought to the emergency right away. So if there is a trauma, you should think of bleeding, like a patient who fell down and presenting with headache. Also, it's important to know whether there is other medical conditions like hypertension, because sometimes uncontrolled hypertension can bring the patient to the emergency department with headache. Usually those patients with severe hypertension, what we will also find in their exam. هذا بعرف. Yes, واللي هو كيف بنشوفه بالطوارئ كيف نعرف إنه موجود. Yes, we send them to the ophthalmologist to test for papilledema. What other disease needs to be tested for papilledema? شيء more simple, يعني حدا young, especially female, childbearing age, obese. Sorry? ABS? شو ال ABS? No. ممكن بس بنحكي عنها بعد شوي ليش ممكن تكون بس في شيء more common disease اللي هو idiopathic intracranial hypertension أو اللي اسمه the other name pseudotumor cerebri. So those patients usually they are female patients in the childbearing age. They usually have overweight. Or they present with chronic headaches. When you test for papilledema, you will find papilledema. Sometimes if you're still suspecting that, even without papilledema, when the pressure is not that much high, you need to test them for the pressure, opening pressure, CSF opening pressure by doing lumbar puncture. زميلتكم حكت انتي فوسفوليبيد سيندروم، حدا بيعرف كيف الانتي فوسفوليبيد سيندروم can increase the intracranial pressure؟ ايش بتعمل الفوسفوليبيد سيندروم بالفاسكولار سيستم؟ تعمل فينوس ثرومبوسيس. فلما صرنا في cerebral venous thrombosis, patients will present, this is an emergency cause of headache, and patients can present with increased intracranial hypertension. So you can find papilledema also in those patients. So this schedule just summarizes most of the important headache types like the migraine, the cluster, the stabbing headache, subarachnoid. وفينا كمان temporal arthritis اللي هو ايش بكون؟ Yes. Temporal area, yes. So they present with also blurred vision. Usually they are above the age of 50, so you should check two blood tests اللي هم ESR, CRP. They usually have high ESR and CRP. And the treatment is with mainly steroids. So the schedule just showing the primary and the secondary headache. You need to know that the primary mainly migraine, tension, cluster. They are called primary because there is no secondary cause. Okay, we spoke about this. Okay, loss of consciousness. This is also one of the most important symptom in our field, especially ER. Most of the time we deal with loss of consciousness cases in the emergency room, especially when it happens for the first time. Sometimes, rarely, they present to the clinic when it is repeated more than one time and they don't know what's the cause, so they bring it to the neurologist. حدا بيعرف شو ممكن نسأل بمريض loss of consciousness؟ ايش نعرفه؟ ايش؟ description للأتاك، فإحنا we need a witness. Most of the time بيكون حدا من parents أو حدا من family. فالwitness is very important. Usually we speak with the witness because the patient is not aware about what happened to him. So بهمنا نعرف how was the attack. Was it just a loss of consciousness only without any other symptoms like what? إذا في jerky movement. The tonic-clonic seizure, they present with jerky movements. If there was also frothy mouth secretion, this is also moving us towards seizure. If there's uprolling of the eyes, if there is urinary or stool incontinence, this is also can be a seizure. And if there is post-ictal phase, usually patients who are having a seizure attack, they tend to have a post-ictal phase. When the seizure stops, they won't gain consciousness right away. They need time till they recover completely. So they will pass through a period where they are confused, disoriented, sleepy, and then when time passes, they go back to their baseline. So these are the most important associated symptoms that you need to ask about. Also, we need to know what was the patient doing. Most of the cases like syncopal attacks may happen when the patient is doing excessive exercise, or when upon standing, we should think of postural hypotension. It's not a seizure. We need to ask about palpitation because this loss of consciousness can be a syncope due to arrhythmias. So it's not easy sometimes to diagnose seizure. What tests we use to help us diagnosing a patient with epilepsy? حدا بيعرف؟ لا احنا بنحكي عن test investigation we use to evaluate patients with possible epilepsy. اللي هو ال EEG, electroencephalogram. The EEG, unfortunately, if it is normal, it will not help you because it doesn't rule out epilepsy. While if it is abnormal, يعني شفت في sharp waves, this means this is a case of epilepsy. بس إذا كان free or normal, you should keep epilepsy in mind. Then most of the time when we do the EEG, the brain activity is almost within normal. The patient is not having an active seizure. So we expect to have a normal EEG. طبعا احنا during the EEG بنعمل للمرضى شيء اسمه photostimulation. There is بيكون في light, بيعطي flashes of light while doing the recording لأنه كمان light is a triggering factor for seizures. So we trigger the brain activity and to see to lower the threshold of seeing these epileptogenic discharges. Also, we ask the patients to hyperventilate. Hyperventilation sometimes can trigger seizure. إذا في patient يعني كنا عم نحكي عن hyperventilation، إذا كان في patient arrived to the ER with hyperventilation and she said she was having loss of consciousness, you are dealing with what? Sorry? يعني هاي ممكن تصير as a complication بس بشكل عام إيش diagnosis? Is it a seizure or what? This is most of the time is psychological. So psychological cases, they usually present with hyperventilation. And when you go back to the history, you will find a stressful condition like exams, etc. So it's very commonly seen in the emergency room. And sometimes they are misdiagnosed as seizures. We are called to the ER and then you find that this is not a true attack. طبعا احنا عندنا كثير بالنيورولوجي this is very difficult thing for us انه بيجينا كثير مرضى with يعني بتعرفوا التيرم malingering. So most of the time they tend to use neurological symptoms like loss of consciousness, weakness. So we have our tricks in the exam to know whether this weakness is true or not. Anyone know how we examine this? Okay, a simple trick we use. Usually patients who are having true weakness, when you raise their hand, it drops, right? So the patients who are having a true weakness, when you raise their hand above their face, لأنه بكون مريض supine position, the hand will drop over their face. While patients who are having non-true weakness, they tend to drop it on the bed to avoid harming or hitting themselves. So this is one trick. Another trick we use what is called distraction. So sometimes I hold the patient's hand or arm against the gravity and I start discussing and asking or giving some tasks like, can you count from 100 to 0 backward? Then you leave the patient's hand. Sometimes they forget that they have weakness, so it will be kept in the against the gravity. So you should know some of the tricks when you come to the neurology rotation. We may speak about them more. Okay. زي ما حكينا, it's important to know if the patient had already did some investigations like MRI, EEG, because this will help you to diagnose, or even if the patient was already diagnosed with seizure, because this means if, for example, he had a previous attack and he presented today with the second attack, our rule in neurology is 2 attacks of seizure should be treated, while the first one we wait unless there are some points fulfilled by the patient, like abnormal EEG, abnormal MRI, abnormal clinical exam, a positive family history, nocturnal epilepsy. Some patients have their seizures just while asleep. So this type of seizure has a high risk of recurrence. So we tend to treat them even from the first time, and also those with family history. Okay, these are the differential diagnoses for loss of consciousness. As we said, it can be a syncope like vasovagal attack or carotid sinus issues, or it can be of a cardiac origin. That's why if we are not sure if this is epilepsy or not, we send patients for shoot test اللي بنعمله مع الكارديولوجيست. مش ECG sometimes can help, بس في شيء more accurate اللي هو Holter monitor اللي هو a continuous ECG recording. Usually it's a small device بركبه المريض على ال chest area, يكون فيه small leads, و it records the heart rate and rhythm for 24 to 48 hours. Usually we leave it. Then we print the data and then cardiologist will take a look. لأنه احنا في عنا arrhythmias that are paroxysmal. So when you do the ECG, it will not pick or catch these arrhythmias. Postural hypotension, like patients who are taking antihypertensives or patients who are taking الدوبا. الدوبا اللي هو الليفودوبا. تعرفوا وين نستخدمه؟ الليفودوبا. Yes, مع Parkinson disease لأنه عندهم dopamine deficiency. Besides the Parkinson itself can cause postural or dysautonomia, كمان الدراجز تاعت الباركنسون بتسبب postural hypotension. And finally, functional or هي psychiatric, زي ما حكينا عن بعض examples اللي كان present to the ER. Okay, these schedules are just differentiating between the main 2 types of seizure. Seizure, usually we classify it as either generalized or focal seizure. Focal also, we have some categories and subcategories, like whether it is focal seizure with impaired awareness. هذا التعريف الجديد صار لها الترم الجديد, focal seizure with impaired awareness اللي كانت زمان تتسمى complex partial seizure, أو إذا في عنا focal seizure with preserved awareness اللي هي simple partial seizure. The focal or simple partial seizure, they usually have involuntary movements or sensory symptoms only in one part of their body, so it's not generalized. ممكن patient they just present with jerky movements in the right upper limb. If the patient is able to speak and reply to your questions, this is a simple partial seizure. But if there is any defect in the consciousness or sometimes they can speak, but the speech component is not comprehensive, this is called complex partial seizure. One of the generalized seizure type, the most common هو tonic clonic اللي عادة نعرف عنها بس في عنا other types. They can either present with atonic, just a flaccid, or for example absence seizure. Absence is considered a generalized seizure type. So they usually just stare and after a few minutes they go back to what they were already doing. Those can be frequent and usually seen most of the time with child ages, or most of the time either the family or the teacher reports these episodes. Okay, this schedule just differentiating between vasovagal attacks and seizure. So vasovagal attack usually triggered by pain and emotions, while seizure either sleep deprivation or alcohol or withdrawal or drug withdrawal. Sometimes drugs can induce seizure, like some painkillers or anesthetic agents. They can lower the threshold for seizure. And of course, the seizure triggers are many. So if you are not dealing with a case of epilepsy and seizure is a symptom of something, you need to check, especially with first onset seizure, like electrolyte disturbances, hyponatremia, hyperkalemia. All these can cause seizures. Infection, like even a simple UTI, sometimes fever itself can be a trigger for a seizure attack. Patients usually with vasovagal syncope, they feel like fainting and they may have visual dimming and nausea, tinnitus, while the prodrome of seizure, especially the focal onset one, these will not be always present. The vasovagal attacks usually are very short compared to seizure attack. بس إذا عندنا مريض with seizure, it lasted more than 5 minutes, what we call this? Status epilepticus. So any seizure above than 5 minutes, or 2 seizures in between, there is no regain of consciousness. These are called status epilepticus. This is a very top emergency. Patients with vasovagal syncope, they tend to be pale, while seizure patients, sometimes they have bluish discoloration because of hypoxia. When they seize during the seizure, the O2 saturation may drop. That's why in emergency room, we start with the ABC, which is the airway. We check the O2 saturation and we put patients on O2 mask, and usually, or it's a must also to put them on one of their sides, either the left or right, whatever. لأنه عندهم حكينا بصير في frothy mouth secretion. Those patients are unconscious, so we are afraid that they may swallow these frothy secretions, and if they did, these can go or pass to the airways and cause aspiration and pneumonia. Tongue bite, most of the time present in generalized seizure, but it's not a must. So مش كل مريض عنده generalized seizure will present with incontinence or tongue biting, but it can be there. The recovery usually rapid بالvasovagal, while حكينا بالseizure في عندهم post-ictal phase, so they tend to take time till they fully regain consciousness and resume their activity as before. ويعطيكم العافية. عنده أي سؤال؟